Welcome to the October issue of the Journal of Vascular Surgery. The paper of the month, Preoperative Risk Score for the Prediction of Mortality Following Repair of a Ruptured Abdominal Aortic Aneurysm, is by Garland and co-workers from the University of Washington. They studied 303 patients over a 10-year period with a ruptured aneurysm and identified 4 variables, as shown in Figure 1, from the 145 collected. These included age more than 76, a creatinine greater than 2, a pH less than 7.2, and a blood pressure less than 70 millimeters of mercury that were associated with an increased odds ratio of death, ranging from 2.11 to 2.70. They then used these 4 variables to develop a point system for risk of dying within 30 days of a post-aneurysm rupture repair, with each variable receiving 1 point. When applied to their patients who had both endovascular and open repair, all with 4 points died, as shown in Table 6, while those with 1 point had a 22% mortality, those with 2 points had a 70% mortality, and those with 3 points had an 80% mortality. Although not validated by a separate group of patients who underwent EVAR and open repair of ruptured abdominal aortic aneurysms, the authors believe that this risk score predicts 30-day mortality with both techniques, and that this information can be used when considering transfer of a patient to a tertiary care center, as well as for preoperative discussions with families regarding the likelihood of survival. The next paper, Long-Term Comparative Effectiveness of Carotid Stenting versus Carotid Endarterectomy in a Large Tertiary Care Vascular Surgery Practice, by Garvin and co-workers from Geisinger Medical Center, is a real-world comparison of the outcomes when fellowship-trained vascular surgeons perform both carotid endarterectomy and carotid stenting, with outcome measures of stroke, myocardial infarction, and death. From 2004 to 2014, 1,853 carotid endarterectomies and 478 carotid stents were performed, with short-term and long-term follow-up to a mean of 5 years. 30% of the patients were symptomatic, as shown in Table 1, and 77% had a stenosis of greater than 70%. The 30-day outcomes were similar between carotid endarterectomy and carotid artery stent, as shown in Table 2, with an approximately 1% stroke risk, 2% myocardial infarction risk, and a 0.6% death rate at 30 days, and similar long-term risks shown in Table 3 of a stroke of 7%, a myocardial infarction of 22%, and a death of 28%. The authors conclude that well-trained vascular surgeons can achieve excellent results with either carotid endarterectomy or carotid stent, both short-term and long-term. The next paper, Superior Mesenteric Artery Stenting Using an Embolic Protection Device for Treatment of Acute and Chronic Mesenteric Ischemia, by Mendez and co-authors from Mayo Clinic, reported on 179 consecutive patients who underwent superior mesenteric artery stenting from 2007 to 2016. The indications for SMA stenting included chronic mesenteric ischemia in 74% and acute on-chronic ischemia in 26%. Embolic protection devices, as shown in Figure 1, were used in 36% for severe calcification, which occurred in 34%, acute thrombus in 28%, and total occlusion in 25%. Macroscopic debris, as identified in Figure 2, was recovered from stents in 66%, with 49% having major debris. The authors concluded that embolic protection devices are both feasible and safe and capture debris that would otherwise embolize and could potentially cause acute bowel ischemia. The final paper, which is the CME Paper of the Month, is by Gelabert and co-authors from UCLA and entitled Transaxillary Decompression of Thoracic Outlet Syndrome in Patients Presenting with Cervical Ribs. They report on 818 patients who underwent procedures for thoracic outlet syndrome, as shown in Figure 1, including 873 first rib resections and 56 patients who had cervical ribs resected. The cervical ribs caused neurogenic thoracic outlet syndrome in 49 and arterial TOS in 7. The transaxillary procedure lasted for an average of 141 minutes, had minimal blood loss, and no brachial plexus, long thoracic, or thoracodorsal nerve injury. Patients were hospitalized for 2 days on average and had minimal complications post-discharge. On a mean follow-up of 1 3/4 years, as shown in Figure 3, there was a complete resolution of symptoms in 93% and a reduction in somatic pain score as evaluated on a scoring sheet from 6.9 to 1.3. The authors concluded that the transaxillary approach for cervical ribs has excellent short and long-term outcomes with minimal complications. We hope you enjoy reading these papers and the other papers in this month's issue of the Journal of Vascular Surgery. And thank you for your attention.